welcome back to Roy on Rescue. I wanted to take this opportunity to go through some of the inbox for the Roy on Rescue. There's a lot of emails that come in that I'm not able to get right to because either time constraints or the fact that we've already done a Roy on Rescue episode. But I think sometimes when those videos get buried deeper and deeper into the Roy on Rescue YouTube archive or the WordPress RoyOnRescue.com, it's easy to, well, it's understandable. You wouldn't dig all the way through it to try to find that. There is, however, a search bar, and by all means take advantage of that. If you type in kind of the first, words of your topic that you're looking for, we've got almost 100 and some topics in there, I think. A lot of these reoccurring questions have already been addressed. But by all means, science is always changing, technology is always changing, and I never mind readdressing the same issue twice. I just want to make sure that I get to all of these different particular questions and give them the timely response that they need so that we can either get you to the help that you need or get you the training that's going to help save a life or protect somebody. But what I thought I'd do is I thought I would just go through some of these emailed questions, so bear with me as we work through these, but I thought I would just do kind of it's Monday morning, and I thought what I'd do is just kind of put together a collage of different emailed questions. I'll try not to reveal any of the particulars about the person, keeping their identity safe, and I'll just kind of go through. I might just use a first name. Nobody really knows their last name, so I might just go ahead and do that. But so here's one, and they asked in regards to their choking and I can't get them out of the wheelchair. So you remember that episode where we showed how to address an individual who's in a wheelchair. Maybe we can get them out, maybe we can't get them out. In this particular case, we could not get them out because they were too large or it was an awkward situation and we were unable to get them out. The question was, but won't that make the object go further down the throat? I'm thinking what they're talking about is as we lean the person back, the fear is that now they're laying on their back and they're already choking. Could it actually, lodged further down the trachea? Yeah, sure, maybe. You might ask that question too. If they pass out and they land on their back, is it a potential that it could go down further? I mean, there's a lot of different reasons why the person could actually get the object lodged further down. In most cases, you got to remember, your airway is the size of your pinky. And sometimes it feels like it's, this big. Ideally, it feels that big. If it doesn't, you might be dealing with some kind of obstruction or asthma or something. But in most cases, when you can breathe well, you're actually moving all your air through the size of your pinky. Now, on top of that, you have these larynx, these two cords that open and close as we talk. They vibrate and we take a breath. They open up and the air comes in and then they close when we swallow. They also close and clamp shut when we aspirate, and that could be saliva, water, food, other forms of liquids. Normally that's about where that obstruction is, either right at the top of that or just below it or even right in it, and it's clamped shut. We're going to do those chest compressions, which forces trapped air up the trachea to pop that object out. If it moves down a little bit further, ideally, if it's a solid enough occlusion that they can't get any air in or out, what we're hoping for is to forcefully press down on the chest to bring that trapped air that's in the lower lobes of the lungs, move it out of those lower lobes, up into the dead space or the tracheal area, and like a cork gun, pop that object up either to the gag reflex where they'll vomit and get the rest out, or they'll be able to, it'll be visual, and we can go in and sweep in an unconscious patient, ideally with a gloved finger, reaching into the side, sweeping behind the object, and then pulling the object clear, and then trying to give a couple breaths. If the individual is conscious, obviously if it gets to that point and they can feel it, they'll spit it out, they'll cough forcefully, it'll come out the rest of the way, they vomit, etc., and we know it's clear. yeah, there's a little bit of risk, of laying the person down, and especially the individual is not going to feel real good about it. But in an emergency, this thing is already lodged, or we wouldn't be leaning the patient back. So it's not going to move it that much further down, in my experience, to worry about that. And if we're able to lay them down and actually do chest compressions deep and fast and blow that object up and out, that's going to be ideal. So that's still going to be per the latest ILCOR guidelines. That is the best treatment we can do. And again, remember I said too, if they can stay sitting up and we can come around behind them by removing the arms of the wheelchair, coming around to the sternum and go directly into the sternum, that's ideal. It's when they're too large to do that. Now we're in a last-ditch effort. EMS is not there yet. We don't have the McGill forceps. We don't have the suction tubing, the French catheter, the J tube. We don't have any of that stuff, or the tonsil tip rather. We don't have any of that available yet, possibly. So that's why we're leaning the patient back doing chest compressions. So I hope that answered that question. Okay, moving right along, let's get to our next question. Okay, so this next question comes in from Chris, and Chris says, "Hey Roy, I like your videos. I got a question on the chest trauma one. If chest trauma is catastrophic, an example, an aortic bleed, won't CPR just pump the blood out? I thought the idea was to deal with major bleeding before CPR." Well, I think he kind of answered his own question. It's a good question, Chris, and I think what you're really getting at is arterial bleeds of the extremities, or external arterial bleeds, where every time you do a chest compression, you may or may not see a pulsation of blood. Ideally, and let's address that first. I'll get to the aortic rupture or aneurysm in a second, but let's talk about the externals. So you see bright red spurting blood. If it's spurting blood, we know they got a pulse already. So we don't have to do CPR. We can go right to the extremity or to the wound and put an occlusive dressing with direct pressure. Ideally direct pressure over a non-fractured limb. If it's a fractured limb, we still have to somehow control that arterial bleeding. The newest, latest guidelines, and I'm going to get a little spicy here, the baby out with the bathwater guidelines that I don't necessarily agree with. They've simplified them to the point of almost not being useful in certain cases. We used to do the pressure point management above the fracture site, which would buy us enough time to clot, to splint, and then to wrap with a pressure dressing. That's not being taught currently. Is it still effective? Yeah, I think it still has effective principles that can be applied. I teach per the guidelines because you need to have an accredited CPR certification, first aid certification, but now we're talking RoyOnRescue. And as far as I'm concerned, there has been a lot of effective pressure point management. We used to do it in kidney dialysis when we had an individual who had a bleeding issue with their port, which is basically a blood vein that's been reattached to an artery, and it kind of blows that up big, and then that's where their dialysis needles go in. Sometimes they wouldn't stop, especially if we had them on Coumadin or something like that, blood thinner. And direct pressure would be great, but if we could go up above that and do some direct pressure management, you could almost slow that bleeding rate down without necessarily affecting the peripheral circulation. So I still think there's a time and a place for arterial bleeding management with pressure point management, and especially because what if you can't put direct pressure on a fracture site? Now, the national guidelines might argue with me and say, well, that's what tourniquets are for. However, tourniquets are being argued too right now, a little bit back and forth. There's definitely a time and a place for tourniquet usage as well. And so I guess if you weren't comfortable doing pressure point management, the pressure point management wasn't working, you had a fracture, you didn't want to put direct pressure on that fracture, causing it go from simple or a complete fracture into a compounding fracture, yeah, you might have to deal with a tourniquet at that point. Now let's quickly move that to the person that has got a problem with bleeding and they don't have a fracture. Direct pressure. Good direct pressure over the arterial bleed. For most people, 6-7 minutes it's going to be all but stopped, and then we can put a dressing over that bandage. Remember, we don't remove it. It'll take the clotting factor with it, and then we start from scratch potentially, and we have to start all over again. So we want to just keep that pressure dressing on there and apply another clean one over that if it gets soaked or saturated, and then when it's under control, we begin to wrap the actual extremity. You can see that in our Pro First Aid videos under bleeding control by going to profirstaid.com. Click on the video tab and get into some of those free trainings and make use of them. But that's a great way to manage the bleeding. And then we monitor the patient to make sure they're not going into shock, which they might be already in early signs of shock, pale, cool, sweaty, rapid pulse. But as long as they stay conscious, they keep their pulse, talk to us, we're in good shape. Now let's say they go into unconscious state. Now we begin CPR. The wound has already been addressed. But if you come across a patient who's got a history of serious bleeding, they're laying in a pool of blood, but they're not breathing normally or not breathing at all, they're not conscious, and they look like they're turning blue around the lips, and we gather that they are in cardiac arrest, we will begin CPR immediately. Ideally, if you had a second rescuer, that second rescuer could address the bleeding issue, bandage it, keep it from leaking anymore, but we're going to go straight to the chest compressions. And once we get the heart beating again, the bleeding becomes an issue again, then we can address the bleeding issue. But non-beating hearts don't leak blood, and we're not going to pump the blood all out of them in most cases by doing CPR. In fact, if they've been in cardiac arrest for any time, chances are that wound is clotted off already. Clotting factor starts pretty fast, and we can just go straight to full cardiopulmonary resuscitation. Quickly to address the aortic rupture, there's nothing we can do to control that. And that is a major cause of death in severe traumatic injury, especially sudden deceleration traumas, where people are behind the steering wheel in head-on accidents. That person is probably, if they're already in cardiac arrest and that's the internal bleeding, there's nothing we can do to treat that bleeding. We're just going to begin CPR and hope for the best. That's something that has to be repaired surgically in the hospital, and no amount of any type of treatment other than cardiopulmonary resuscitation is going to do anything for this individual. So as much as we want to be able to do something, time is of the essence. And if it's a severe enough rupture, if they've lost too much blood, this person's probably in irreversible shock syndrome due to hypovolemia, due to bleeding out inside the thoracic cavity. And CPR is still warranted unless they have obvious signs of morbidity, which means they're already dead beyond any type of resuscitative efforts. This could be decapitation, rigor mortis, cold, and it's a warm day, to where you really think that this is too far gone. That's going to be a judgment call on your part. There's no one going to tell you were wrong for doing CPR, or no one should tell you were wrong for starting CPR, even if there was already signs of morbidity, meaning they've already been dead so long that they're biologically dead and there's no recovery from that. You're going to do the best you can do. You're a true rescuer, and you got to make that judgment call. So so that's just subjective, and everybody's got to make that decision. But that's how we would deal with that. This is going longer than I thought. I don't want to keep this going any longer than this. I still have more questions to answer. It'll probably be in a part 2 of this video series. So until next time, keep on rescuing. I hope this helped, and we'll see you next time. Bye-bye.